Hi, I'm Dr. Udaya Kumar Maiya. I'm the Medical Director of Portea. We are headquartered in Bangalore and we have 24 branches across the country. When you look at healthcare as a whole, the concept of a hospital and a concept of a family doctor was there. There was nothing called a concept of home care. What happened therefore was, for any ailment, people had to go to a hospital or to a local doctor. Because of various reasons, especially the elderly and the terminally ill, because of this particular chore of going to a hospital, seeking attention, waiting for a long time, they'd prefer not to take any medical care at all. Therefore, there was this segment which was totally untapped and neglected. By doing home care, we opened up this segment to the general public and we're giving them care which they never had before, and thereby brought a whole lot of people onto the medical mainstream. So this is what I believe home healthcare has done, and with our experience in the last 2 years, we have given, at the rate of around 60,000 visits a month, we opened up a new dimension in healthcare in India. What has happened is, because of inaccessibility or ignorance or plain inertia to seek medical attention, a whole lot of health parameters have been neglected. By proactively taking each one of them stepwise, for example, vaccination. Everybody knows vaccination is good for health. Everybody knows they have to go get themselves vaccinated to get avoid getting infection in that particular area. But how many of them do that? Proactively getting them vaccinations, for example, proactively visiting them, checking them out, delivering medical care. What we're doing is that clinical inertia which the patient has is counteracted, and we're bringing that particular health factor to their doorstep. They can't just avoid it. After some time, it becomes a habit and healthcare becomes the primary focus. The problem with today's healthcare is that everybody goes to a hospital, especially a busy hospital, for everything starting from a major surgery, which is justifiable, and also to show a prescription or to have a wound dressing or an injection, which is not advisable, for the simple reason that the hospital is a place where focused healthcare is given. So this OPD clutter, as I would call it, can be avoided by doing all the minor things at home. And the hospitals also appreciate this particular benefit, because they realize that 4 or 5 patients with dressing compared to one patient who has an appendectomy is more useful. Secondly, what happens is the hospital's income is maximum in the first 3 days of hospitalization, and if a patient decides to stay in the hospital for 3 more days or 4 more days just to take injections and dressing, they're occupying valuable hospital space which can be better utilized for an acute care patient. But the hospitals had no choice, they kept on doing this. But now that home healthcare has come in, they can easily offload this population of patient onto us and use the hospital beds for better information or better care delivery, and home healthcare takes over whatever they would have done in hospital. Therefore, we work in partnership rather than in a confrontation mode. Technology definitely helps in terms of bridging this particular gap. There is no way technology can physically replace the doctor shortage or the paramedical shortage, but it can optimize the resources wonderfully well, thereby to a certain extent take care of the crisis of this particular shortage. By this I mean having doctor apps, by having cloud-based web systems, by having efficient electronic medical records, and by delivering efficient home care. We do not, for the time being at least, feel the pinch of the shortage of doctors and medical personnel. The problem with diabetes is that it is one of the huge sectors which eats up the chronic healthcare space. We're talking of something like 40 million diabetics present today, and the number is increasing. That's point number one. Another issue with diabetes is, initially it is asymptomatic. Until you screen for it, until you look for it specifically, one does not realize one has diabetes. After the diagnosis is made, once again the outcome may not be very measurable, so patients tend to be less compliant to treatment for diabetes. Thereby they do not take the treatment. At least 1/4 of them do not take the treatment. So what happens, diabetes in effect, is when they develop a complication of diabetes, will they realize it's a chronic ailment, and by which time it may be too late. What we can do in the home care segment is to take this particular population which is vulnerable, bring them onto the mainstream and give them the care which they deserve, and thereby prevent complications and thereby prolong the lifespan of a diabetic patient. It is many of our home healthcare clinicians want flexi hours, want comfortable working patterns, do not want night shifts, do not want various other factors, and these are the ideal people who can work for us at their particular moment in time. There are a lot of people who have a couple of hours, 3 hours or 4 hours to spare, be it a nurse, be it a doctor, whom we can very gainfully employ. No other place can have such short span of employment for these kind of people. So we have the consultant model, we have the part-time model, so we can gainfully employ these people in their areas of interest. Thereby we can tap onto this particular latent force which is otherwise going unutilized, then bring them into the mainstream as far as healthcare delivery is concerned. Thereby we can optimally use our medical resources, which is very, very short, for the betterment of everybody concerned. Chronic diseases are on the rise. The population is getting older, and with old age, chronic diseases increase. About 1/4 to 1/3 of our 60 plus population will require medical attention, hospitalization, and home health care sometime in their life, cycle. We have noticed that diabetes is a very rampant issue in our country. We have realized that old age is a rampant issue with its own trappings like immobility problems, with hypertension, with cancer, with neglect of their health, and thereby developing complications. They don't die, at the same time they're not living an ideal lifestyle which they ought to be living as senior citizens. So we have noticed that this particular area is neglected. We have noticed the magnitude of this particular problem. We realize that every fourth or the third patient whom we see in the 60 plus category is a diabetic or a hypertensive or a demented patient or with stroke and various other problems. So we realize that chronic diseases are here to stay, and with age they're going to explode in our faces if we do not take appropriate action at the right time. If you take individually, geriatrics is a key population, key sector for us. Chronic ailments like diabetes and hypertension are key segments. Cancer is a key segment, and plain, simple, uncomplicated old age is another segment which we deal. But unfortunately, nothing happens in that watertight compartments. We have cancer with diabetes, we have hypertension with cancer, we have old age with any of these conditions. Therefore, they are all interlinked. So anybody 60 plus will have all these problems, and I believe this forms a very niche segment in our care delivery system. The challenges are, there is first of all ignorance about this kind of services which are available. The first thought which comes to anybody's mind when somebody has a problem is, let's go to a hospital. That mindset has to change. Number two, the challenges are that we need to have a very good handshake with the existing medical systems like nursing homes and hospitals. It is for their own good for them to be associated with something like this for two reasons. Number one, they can offload their extra work onto us, and they can make sure that continuity of care is maintained. So these are some of the challenges we face. Awareness is one, coordination is the other, and bringing the whole thing under the gamut of healthcare is the third. It is extremely cost effective in the sense that cost necessarily need not be in terms of rupees and paisa. We are talking about time spent in the hospital, time spent in combating infection because you acquired these infections in hospital, time spent for the son or the daughter to apply half a day's leave, take the patient to the hospital. All these are cost savings because whatever treatment delivery we do it at home, and it usually works out to 1/4 to 1/3 in terms of cost benefit to the patient compared to the same treatment being delivered in the hospital.